So I'm going to speak on cardiovascular disease today and stroke. So we'll talk about the brain and the heart. This is why I put red colors. My slides also with a red background. It is really a very important webinar that we're going to have. Will be translated in Spanish. It's being translated, and thank you for the Spanish translator. Will be also translated to French. Merci au traducteur français. And will be translated in Ukrainian also. Thank you for the Ukrainian translator. And we'll have in an hour and 10 minutes, Michel Delorgelil, a famous professor in France, who is not afraid of fighting established ideas and the establishment. He's a researcher. He's the one behind the French paradox, made research to see that drinking wine could be helpful for cardiac patients. He also points on the weakness of the statin studies. And so he's not a proponent of statins. And also he has done a lot of research on Mediterranean diet and on omega-3, how these omega-3 polyunsaturated fatty acids help us to be healthier. I have a lot of admiration for him. He does a lot of good work, and we need people like him. So he'll be interviewed. And so let's start now. This webinar is on what can hormone therapies do to help us prevent or reduce hypercholesterolemia, serum triglycerides, homocysteine, lipoprotein A excesses, arterial hypertension, coronary heart disease, and cardiac arrhythmia and heart rate variability, and heart failure. And I'm especially interested because I had personally some health problems, cardiac and vascular, that are partly came after my bad reaction on the COVID vaccine, but have also been very amplified, just recently found it by eye drops I put in my eyes, and that contained a beta blocker that completely gave me a severe bradycardia, and I had to stop exercise because of that. So finally, I found where it come from. So we need alternatives for cardiac disease. We need also adjuvant treatments to the classical cardiac drugs so that we can keep our heart healthy. Our heart is really very important thing. We live with our heart. Nobody is really living if he doesn't live with his heart. If you're in your brain all the time, you're not really living, you're existing, but you're not really enjoying your life fully as you could. And so the model has all these different sessions of 2 hours on stroke, heart failure, and things like that. Really interesting. And you will see that hormone therapies are almost essential once you get older to prevent heart disease. And let's go first and look what can be done with hormone therapies for hypercholesterolemia. Well, there are hormone therapies can work on the total and the LDL cholesterol. They can increase the HDL cholesterol. They can decrease the antibodies against oxidized LDL cholesterol, which really, what is really important with cholesterol is that when it oxidizes, it can start an atherosclerotic process. So hormones that can decrease oxidized LDL cholesterol are welcome. And you see there are several of them. I'll probably briefly talk about some here because we don't have time to go to all over everything. So we have hormone therapies that can decrease triglycerides, homocysteine, lipoprotein A, and the CRP. And so let's look at the most efficient hormone therapy to decrease hypercholesterolemia. That is thyroid therapy. And here you have a study in adults with hypothyroidism and adults with hypothyroidism. And they were followed initially before they got in treatment, and during the treatment, they received to normalize their thyroid hormones. You see, the hypothyroid patient actually have a very high serum cholesterol at 10 millimoles per liter, and then it decreased gradually over 6 to 12 months. But the most of the efficacy was here in the first 6 weeks to 2 months. And hypothyroid did the opposite. They had very low levels of cholesterol that was overconsumed by too much metabolism. And you see, for example, that after 6 months, of T4 treatment in this case, which is not the most efficient treatment but it's an efficient treatment if you're very severely deficient. The greatest decrease is 32% decrease in serum cholesterol, the greatest drop already after a month, just that. And so what is the efficacy of a thyroid hormone to decrease the cholesterol? Here you have a study on just 22 patients, but it's really symbolic for what thyroid hormones can do. And these patients had primary hypothyroidism with high lipids. And you see that the L-thyroxine was given doses between 50 to 100 micrograms per day for a mean of 60 months. But the average dose was about 150 micrograms per day. And that dropped the cholesterol by 47%, which is really important. Of course, they had a very high cholesterol of 387, dropped to a normalized 205 milligrams per deciliter. And so most patients had a normalization of this cholesterol. And the researchers concluded hypothyroidism is a common reversible hyperlipidemia. We knew this already in 1977. This was a study, and even before. And since then, not many of those patients are treated with thyroid hormones, while you should probably suspect, if a person has a very high cholesterol, that there is hypothyroidism. So which thyroid preparation produce the greatest decrease in cholesterol? Is it thyroxine? Is it T3? Well, actually, my experience, it is desiccated thyroid. That is actually the best, and I won't show all the studies because that you find in the model, but also because we have to run a bit through several topics. And but just let me tell you that there are studies showing desiccated thyroid to be better than thyroxine or a T3 and T4 combination, although there are also studies show that T3 alone may even be better, but you need to give it 5 to 6 times a day. That's the problem of giving T3. Now, what is the second most efficient hormone therapy of hypercholesterolemia in women? Well, in my experience, it's giving female hormones. And here you have an example. You have healthy postmenopausal women who have been hysterectomized, and they receive only oral estradiol or transdermal estradiol. Some do receive some synthetic progesterone. And after 1 year, you do see changes in 5 to 11% of serum total cholesterol. The LDL cholesterol decreased by 6 to 14%, and no significant change in HDL cholesterol. There are better studies than that. There's a study here with implants. An implant was given every 3 months with or without testosterone, and that gives a sustained decrease in total cholesterol and LDL cholesterol. You see that actually female hormones do not decrease the cholesterol as much as the thyroid hormones. Thyroid hormones is by far more potent, and it's indicated when you have a deficiency in thyroid hormones. What is the fourth, in my option, most efficient hormone therapy for hypercholesterolemia? Melatonin. Melatonin. Here's a study, for example, in adults with Parkinson's disease, and half of them were treated with melatonin and half of them were treated with placebo. And they received for about 3 months a dose of 10 milligrams per day, which is a very high dose, but not dangerous. You cannot kill somebody with 10 milligrams a day or even 100 milligrams or 1,000 milligrams. And compared to placebo, it decreased by about 13 milligrams per deciliter the serum total cholesterol, so something like 7% decrease of the cholesterol, which is on its own not so much, but it's a significant result, and it does helpful. Now, what is important is also decrease at the same time the LDL cholesterol. So you do improve the global situation. And studies have shown over and over that with melatonin, you need to give doses from 8 milligrams or more to be efficient. And those are supraphysiological doses. I take myself, for example, for sleeping 0.2 milligrams sublingual. But sublingual is more potent than oral. What I take may correspond to, no, I take actually 0.1 milligram. What I take corresponds to 0.5 milligrams orally. Now, what about the triglycerides, the homocysteine, the lipoprotein A that can be in excess amounts in our blood? So hormone therapies can decrease triglycerides, homocysteine, lipoprotein A, and even the CRP. And we're going to see for the hypertriglyceridemia, what is the third most efficient hormone therapy? That might well be growth hormone and IGF-1 therapies. A person who's growth hormone deficient is a person who's fattier, heavier. In general, they have more fat, less muscle mass. This is a person who was like that for 18 years. And then by taking growth hormone for 2 years, see the efficacy. It shrinks, takes fat away. So growth hormone is a fat-reducing hormone also for the serum lipids. Not as potent as thyroid hormones, but still it is efficient. These are 32 growth hormone deficient adults compared to healthy adults. They had 2 times higher level of the serum triglycerides compared to healthy adults, those growth hormone deficient adults. And when you give a growth hormone treatment to stroke patients, for example, they usually have low IGF-1 levels, so low growth hormone deficiency. And after 6 months, it did significantly decrease the triglycerides and the LDL cholesterol. So that's beneficial. And here, a woman with Turner syndrome, they received growth hormone treatment, but it gives them a better aspect and makes them feel better. And with growth hormone treatment, they compared to a control group that didn't receive the treatment, 27% decrease in serum triglycerides. And it also decreased the total and LDL cholesterol, increased the HDL cholesterol. And here, another study in growth hormone deficient adults, for 4 years, growth hormone treatment was given, and that did not significantly change the serum triglycerides. So that means that the growth hormone treatment is not a major treatment to decrease the serum triglycerides. The best actually is thyroid hormones again. Everything that concerns the serum lipids is actually their thyroid hormones are more efficient. What is now then the most efficient hormone therapy for hyperhomocystinemia? I'm sure you guessed it, thyroid therapy. And so how low should the serum TSH drop to decrease the serum homocysteine in hypothyroid patients? Well, this is the study done with L-thyroxine treatment, and we had adults that had a high TSH despite treatment. They were still with too high TSH, and that they had the highest serum homocysteine of all the group. When adults had a serum TSH between 2 and 5, so between the reference range of the lab, they had a 16% lower serum homocysteine. But the adults who had a serum homocysteine below the 2, and between 0.4 and 0.2, they had the lowest serum homocysteine. So you need to, here, to decrease this homocysteine, to be at least below the 2 and preferably even below 1. Other studies have shown that for other lipids, you decrease them with thyroid hormones if your TSH is actually between something like 0.4 and 0.8. So you need to be low normal in TSH to decrease. And with thyroxine for the cholesterol, for example, it is you need to have a suppressed TSH to have the greatest decreases of total and LDL cholesterol. And in many cases, suppressing TSH during a thyroxine treatment does not have clinically hypothyroid consequences. So you think about that a low TSH is better. But for the heart, I would say stay between 0.4 and 0.8. I think that is you're without danger with the treatment. So, but for the homocysteine, you need to be below the 2. And we go further. What is the second most efficient therapy for excessive serum lipoprotein A in men, well, that might be testosterone, but I did put a question mark because we don't have enough data. We don't have meta-analysis. We don't have placebo-controlled studies. We do have control studies, but it's mostly studies from before initial treatment and then after with treatment. But it still is interesting because when you look at men with coronary heart disease, for example, Chinese men, those who had very low levels of testosterone below the lower limit of young men, they had actually a 47% increase of the serum lipoprotein A. So that's high. They really had higher level than men who were above that level. And here's a study with 12 healthy young men and 10 healthy men, 2 studies actually. The first week, they gave a chemical castration. They blocked the secretion of testosterone and with a medication. And that gave a 55% increase in serum lipoprotein A. So if you have no testosterone or you're very low in testosterone, your lipoprotein goes up by about 50%. Also in 10 healthy men, 5 weeks of chemical castration gave 36% increase in the serum lipoprotein A. So many people believe that this thrombogenic protein that can cause thrombosis, and then some believe that can cause atherosclerosis, that this there's no treatment to decrease it. It's a genetic. No, it is not. It is linked to hormones. And testosterone is probably the second best treatment to decrease it, probably because we're still with question marks. But thyroid therapy also here may have even more efficacy. And what about adult growth hormone IGF-1 treatment? Here, there's a little critical point, is that growth hormone treatment has been shown in several studies to increase the level of lipoprotein A. The growth hormone can increase the level of lipoprotein A. While it is reassuring for all other lipids, it tends to decrease the total and LDL cholesterol, apolipoprotein B, triglycerides, CRP, etc. Can even decrease the CRP by 60% in one study. Here you have Polish children with growth hormone deficiency compared to healthy children. That was reassuring. They had actually 4 times higher serum lipoprotein A. So, but the levels were relatively low anyway in the healthy children. So here you would think growth hormone deficiency would promote actually high lipoprotein A, and so that's reassuring. If you give growth hormone treatment, you would do the reverse. But here's a study with Scandinavian adults with growth hormone deficiency, and compared to healthy adults, they had significant decreases in lipoprotein A at baseline. And so they had actually lower, being growth hormone deficient seemed protective for that lipoprotein. And when they received growth hormone treatment that brought them in the upper serum IGF-1 range, the increase in serum lipoprotein, but not to pathological levels. It was still normal levels. Here's a study with 32 Japanese children with growth hormone deficiency who received 6 months of who received growth hormone treatment, but then stopped. And after 6 months of stopping, their serum lipoprotein decreased by 72%, down to 11, while it was 40 milligrams with serum lipoprotein. So there is some restrictions for growth hormone, and that's why you should not overdose in growth hormone. Now, what about arterial hypertension? Can hormones do something that you can put your medication on the side? I'm not pretending that hormone therapies can do everything for the cardiovascular system, but I do pretend that in most cases of hypertension, of stroke, of heart disease, there is a need to at least additional hormone treatment to strengthen the body of the person and prevent cardiovascular disease from worsening or even to appear. So the number 2 treatment for women to decrease arterial hypertension is to give them transdermal estrogen. I'm stressing the word transdermal, not necessarily oral, and progesterone therapies, and I'm stressing the word that it's bioidentical progesterone I'm talking about. And so you have women with premature ovarian failure. During 12 months, they had either synthetic derivatives of female hormones, oral etenyl estradiol and nortestosterone, which is a birth control pill and so on, and physiological treatment with transdermal estradiol and vaginal progesterone. And the transdermal estradiol and vaginal progesterone compared to the oral etenyl estradiol and nortestosterone showed actually that there's a 24-hour decrease in systolic and diastolic blood pressure throughout the treatment. So there was more decrease, or there was a decrease of systolic and diastolic blood pressure with transdermal estradiol and vaginal progesterone. It's better than with oral forms. And the decrease is about 7.3 millimeters of systolic blood pressure less. It's not enormous. If you have 130, for example, you go down to 123, but that's a safer blood pressure. And the diastolic blood pressure decreases also proportionally even more. It's quite similar, 7.4 millimeters of mercury. But if you decrease from an 80 to 73 millimeters of mercury diastolic blood pressure, you're better off. These are significant values. Also, the kidney function improved, so that decreased the serum angiotensin II, and the serum creatinine decreased with female hormones. So you activate less the serum angiotensin II, so you have less risk of increasing your blood pressure. And the number 5th treatment, I think, in order of importance for arterial hypertension, can be called melatonin treatment. And a meta-analysis of 7 trials with 220 adults actually showed that the slow-release melatonin with doses of oral 2 to 2.5 or 3 milligrams per day actually significantly decreased by 6.1 millimeters of mercury nocturnal systolic blood pressure. So also, it's very significant even, you have P of 0.0009, and the nocturnal diastolic blood pressure decreased by 3.5 millimeters mercury. So what you hear here is that melatonin decreases the nighttime blood pressure. You need at nighttime the blood pressure to drop. Some people, it doesn't drop. Then they need to take melatonin, and most of them can improve very well. The fast-release melatonin, so the usual one that you use, not an extended form, we did 4 trials, despite 5 milligrams per day was given, so a high amount, actually no significant effect on nocturnal systolic blood pressure. So that stayed about the same, no significant effect on nocturnal diastolic blood pressure. So you need to have a slow release form, or to take it twice during the night, the second time, to have substantial decrease in blood pressure. Now, these decrease in blood pressure are not as much as can be obtained with thyroid therapy. Thyroid therapy, again, is extremely important to decrease blood pressure, especially diastolic blood pressure, but we don't have the time to go that over. But I just mentioned it for you. I like to tease you so that you would get and search the information, or you would, and that would be even better, you would participate and register for the module on cardiovascular disease that I've just done. The number 3 treatment for arterial hypertension can be DHEA. So it's not the most one, but they can help. DHEA therapy, for example, will decrease the blood pressure when it's too high, only if it's due to too much glucocorticoids. Either the patient is taking glucocorticoids or is producing endogenously too much of it. There's no effect on genetic arterial hypertension or arterial hypertension induced with mineral corticoids. It's due to excess in cortisol and not due to excess in aldosterone. What about coronary heart disease? The hormone therapies that help prevent and relieve coronary heart disease, the most information I have in this model is, and I did learn myself a lot by doing, I like to do these models because I always learn, because you always need to have an update of the literature, and there's always new and important information. And so the number one hormone treatment of cardiac emergencies like angina pectoris or myocardial infarction is testosterone treatment in men. It's a super treatment for myocardial infarction. And I need to tell you a little story. When I started medicine, I went to see Dr. Møller in Denmark. And Dr. Møller in Denmark was well known for reversing gangrene in diabetic patients and in other types of patients with high doses of testosterone treatment. And I went to him to know, is this safe testosterone treatment? And he says, in myocardial infarction, you just pour testosterone in a person. You put a Baxter of 6,000 milligrams and you'll save a lot of the damage in myocardial infarction. It's almost your duty to do that. He says it's safe, not dangerous, and you can do it. So he was a very fan, and he had a lot of experience. He had a whole clinic for treating difficult patients. I don't know if his clinic existed anymore because he died 1 year after I went to see him. But it was really something very impressive, and I saw how convinced he was, and he had experience. The second best hormone treatment for prevention of coronary heart disease, probably in men, is testosterone. So let's resume what testosterone does to a man. This testosterone-rich man with a firm face and a firm heart, probably, because what you see on the outside is also in the inside. And you see testosterone deficiency, a lax face, and a weaker heart. You have to suspect a weaker heart because the tissues are in the same state as on the outside. So it's very easy to know who's healthy. If a person has a firm body, that's a healthier person. If a person has a soft body, a weak body, weak heart, probably. So there's more risk of coronary heart disease in such an individual. And you, as a physician or as a health therapist, can do something about it. Here's a very large study with almost 40,000 middle-aged men. Their average age is 46 years, and it's a prospective study. And all these men had low initial total testosterone. And about half of these men received testosterone intramuscular injections 5 years. And compared to those who had the same sort of testosterone values, 7 times less incidence of myocardial infarction in this very large study. And it's 2015, it's not something long time ago. And you see how important it is to treat men with what they deserve to be treated, their testosterone deficiency. It has many other advantages than just preserving the heart. And then also important is that when you give testosterone, men may not make too much estradiol out of it because testosterone is a precursor to estradiol and dihydrotestosterone. And if you drink a lot of coffee or tea or alcohol, or you're obese, you make more estradiol from the testosterone you receive in the treatment. So you need to correct that as a physician in your patients, that they are careful to drink decaffeinated coffee or just water, and they drink little amounts of alcohol. And you see here that men with high serum estradiol in upper tertile have a significant increased prevalence of coronary heart disease. So the higher the estradiol levels are in men, they're above 34 picograms per ml, for example, the more they are likely to have and develop atherosclerosis in the coronary arteries. And so endogenous estradiol and not the testosterone was related to coronary heart disease. High levels of estradiol give more coronary heart disease and not the testosterone. Testosterone is rather protective. But what about estrogen treatment in women? There's the opposite. Estrogens are good for women. It's probably the second hormone prevention of coronary heart disease in women after thyroid, and the possible treatment of small cardiac emergencies because it gives more blood to the heart and it's antioxidant. So these are possible of women who had angina pectoris, that chest pain regularly, but the coronary arteries were normal. And they received transdermal estradiol patches. And compared to baseline estrogen deficient levels, to the initial levels, the transdermal estradiol patches actually almost gave them 4 times higher estradiol levels. And you see that the level of estradiol is 76 picograms per ml. And upper reference range in menopausal woman is 45. Now, this 76 is very important because studies showed that you need to be above 60 or above 70 picograms per ml to have a cardiovascular protective effect of the estrogen. And in response to acetylcholine, they did not vasoconstrict as they did in estrogen deficiency, thanks to the protection of estradiol. And there was actually with the estradiol 50%, not just 10%, 50% more blood flow in the coronary arteries. So the blood was more supplied the heart was more supplied with blood. And what about oxytocin treatment? Oxytocin treatment, as you might know, is the hormone of the warm-heartedness. And I enjoy taking oxytocin because I find life more wonderful and more enjoying. It really makes my heart warmer. But it not only makes it emotionally, it makes it also physically much better. It's the 6th hormone preventer of coronary heart disease, probably, but I cannot put a good position because we don't have data in adults on this, but we do have very good data in rodents. But it's possibly also an emergency treatment of acute myocardial infarction or certainly from angina pectoris. And this is oxytocin deficiency. People are cold-hearted. There's much less affection between a mother and her child when she's lacking this oxytocin. It's really necessary. I'm an oxytocin deficient person. I wouldn't be smiling so easy if I didn't take an additional dose of oxytocin. So I did take it now for this, for me, very important webinar. And there's more coronary heart disease risk, likely more in people who are cold-hearted. And when you are oxytocin rich, you see what the difference is. Warm-heartedness, there's warm-heartedness will probably give less coronary heart disease due to the oxytocin, high levels of oxytocin that is there behind. And so there's a study on rats and rabbits. Oxytocin treatment was given, and it significantly decreased the myocardial injury. So these were rats where myocardial infarction was inflicted. Very cruel studies, I agree. I'm sorry about that. But they do give some information that when they were given oxytocin, they had much less myocardial infarction. And when you blocked the oxytocin receptors with a substance called atosiban, the infarct size was worse, it was bigger, and there were more enzymes showing, levels of enzymes showing that there was damage to the myocard, to the heart. In rabbits, oxytocin treatments before inducing a myocardial infarction reduced the infarct size and were lowered also the risk of ventricular tachycardia and fibrillation. So even the arrhythmia disorders were decreased by oxytocin. But when you blocked oxytocin receptors, again, you abolish the beneficial effect. So again, it is really an oxytocin effect on the oxytocin receptors that is protective. When you give oxytocin after, you also help to decrease the infarct size and make that the heart has less risk of getting into heart failure. You improve the left ventricular function. And it had also effects that there was less fibrous tissue, less scar tissue in the heart. And there was more blood vessels, more micro blood vessels, more capillaries that were open and developed to compensate and cure the myocardial infarction. So they are really cardioprotective effects of oxytocin. And you know, it's at doses that are physiological for men and women. Doses that would be the equivalent of 5 or 10 international units per day intake, which is the physiological dose to take for men and women who want to be more sociable and want to protect their heart. What about DHA treatment? Well, it's not the most potent treatment to prevent for coronary heart disease, but it seemed to be, has its place and also even in emergency treatment, not only in prevention, emergency treatment of acute myocardial infarction. But I put question marks because we don't have data. We have observational studies showing that when levels of DHA are high, then there's less coronary heart disease. So when a woman is DHA deficient, there's armpit hair loss, there's dry eyes, and there's muscle loss, and there's a DHA deficiency that will give coronary heart disease, more coronary heart disease risk. And so there's the DHA has many effects to protect the heart. And you will be probably surprised by how many different effects it can protect the heart. Well, know that hormones like testosterone, growth hormone, thyroid hormones have even more efficacy on the heart. So let's see. So a bad effect of DHA apparently, but without consequences, is that it can cause coronary vasoconstriction and low coronary artery flow. All the other hormones I was mentioning are really protective there. But this was on pig coronaries without an adverse effects on the pig heart, apparently. And then it can mildly, not as strong as the others, decrease the serum total LDL cholesterol, triglycerides, and maybe the homocysteine, because there the data is not strong still enough, but it also can increase the HDL cholesterol in men and women. It can decrease the oxidized LDL cholesterol. And then there are studies showing that it also decreases coronary atherosclerosis. And we'll see one of these studies. It also can increase the density of capillaries in the heart to supply all the cells of the heart with blood. It stimulates angiogenesis, making of new small little blood vessels in the heart for its own use. And it also can, if there's a coronary artery that is blocked, it can stimulate coronary collateral circulation. And it also can decrease cerebral vasospasm. Not necessary, I haven't found a study on the coronary arteries, but usually when you prevent a vasospasm contraction, narrowing of the blood vessel in the brain, you can do that also on the heart. Same process. It also has been shown to decrease cardiac oxidative stress in the heart of diabetic patients, rats. And it also increased the making of new heart cells, and it decreases their death rate, the apoptosis. It also increased the cardiac output and can decrease the fibrosis in the heart. So when you age and when you have DHA deficiency, you might get more fibrosis. It will, giving DHA will counter that sort of fibrosis. So here is something typical for DHA, apparently, at least it has been shown in a study, is that when you have a little stenosis of coronary artery, you generally have a decline of your DHA sulfate. In men, when they have more severe narrowing of the coronary arteries, they have, for example, stenosis in 2 coronary arteries, there's lower DHA sulfate, and then the ones who have more stenosis and in several coronary arteries have even lower DHA sulfate levels. So this is an atheroma plaque here. And so in middle-aged patients with coronary stenosis compared to controls, what was found is that controls had the highest levels of DHA sulfate. Those that had one stenosis that was 50% narrowing of coronary artery was 50% or more, had lower DHA sulfate. Those who had 2 stenosis of more than or for 50% or more narrowing, they had lower DHA sulfate, and 3 stenosis was even lower. So this suggests that there is really a relationship, causal relationship. It's a suggestion, of course. We still need to be careful about this data, but it's interesting that certainly DHA won't harm when you take it and will probably be preventive. And so you see 4% decrease DHA, so 3 stenosis. So a small little difference in the level of DHA can give already a big difference, apparently. These are 2,416 older men, and per 1 standard deviation increase of serum DHA sulfate, you have 4 standard deviation decrease, 2 before the average, 2 after the average. And so you're here within the reference range. And when you go up, you have each time 16% less coronary heart disease events, and like myocardial infarction or angor pectoris, but it doesn't seem to have efficacy on stroke, at least not in this study. And can DHA then make that there's less coronary artery stenosis? Well, a study has been done in rabbits where they left the rabbits like they were, or they caused them a cardiac transplantation, which increases the risk of them of small vessel occlusive disease, of stenosis. And a chronic DHA supplementation compared to controls to these rats decreased to 50% the number of stenosed vessels, both in the transplanted and non-transplanted hearts. So the 50% less coronary stenosis. And 45% transplanted hearts, 62% even the non-transplanted hearts. So it even worked better when you did not give the trauma of a cardiac transplantation. And there were no significant alterations in lipid profiles. So we've seen some of the studies, but there's so much really important studies. Let's go to the other presentations. There's cardiac arrhythmia and heart rate variability. What can hormone therapies do there? You know that the heartbeat originates in the sinus node that is here, and the atrioventricular node that is there takes over, and then in the bundle of His that is here, you have here the right bundle and here the left bundle. That also are the electrical pathways, right bundle, left bundle. And what can hydrocortisone do? Can it prevent tachycardia or arrhythmia? Well, it can probably in stressful conditions. We know that a person who has Addison's disease has some non-specific symptoms. It's tired, nausea, vomit easier, back pain, dizziness, hypertension, syncope, and shock. I am adrenal deficient. I know that when I don't take enough cortisol, and I have enough now, but when I don't take, I have all these symptoms. Low blood pressure, don't feel good in my skin. So I try to treat myself as good as possible. And there is actually, at stressful moments, more arrhythmia possibilities because cortisol is mostly necessary when there is a stress condition. It gives you the energy to face stress and the willpower to do it. And here's a study, for example, a 63-year-old woman who had an ACTH deficiency and deficiency in the hormone that stimulates cortisol production. So there's low cortisol production. And she had a lot of ventricular arrhythmias, as you see here, called polymorphic ventricular arrhythmias. This is life-threatening because that means that the heart will contract in all directions, so it won't be efficient. By giving hydrocortisone, that normalized her QT intervals, and she had almost no ventricular arrhythmias anymore. So she was saved by the hydrocortisone. And here's another woman that had a tumor in the pituitary gland, and that developed in her also ACTH deficiency and thus a cortisol deficiency. And she also had of those polymorphic ventricular tachycardia with a sinus bradycardia. She has a very low pulse rate. I had with these eye drops of beta blocker also an extremely slow heart rate. Didn't even almost not increase. Maximum increase was to 82 per minute. And that was due to beta blocker. So probably the beta blocker might also decrease the cortisol. And you see that there's adrenal deficiency and hypothyroidism in this patient that was examined due to the increase in the tumor in the pituitary gland that crushed the pituitary hormone secretions. So there was less ACTH. So they gave her hydrocortisone because hydrocortisone works quickly in emergency. And later they started the thyroxine, and that reversed totally her cardiomyopathy, her heart disease, and her ventricular arrhythmias disappeared. 44-year-old woman with the same thing, had also frequent torsades of point. It's a sore form of ventricular tachycardia, as you see here. And hydrocortisone was given and also made the torsades, the pointes disappear. What about oxytocin treatment? Can that actually prevent our arrhythmia or ventricular fibrillation? Again, when you're oxytocin deficient, you look more tense or introvert, and there's poor blood flow here, so there's probably poor blood flow in the heart. And when you give an oxytocin treatment, it's better. You see there's more life, and you indeed feel life more enjoyable, and you smile easier. So it makes you extrovert. Oxytocin, it gives you a more emotional expression and more sociability and more facial blood flow. And so the arrhythmia score here is that at social encounters, you had, each time you have a social encounter, you need more oxytocin. If you don't have, you might get more arrhythmia. That's what I conclude out of my experience. It's not a scientific proven fact, but I think I can tell that this is very likely to be so. And so in rats, arrhythmias were caused, induced in the heart by giving a lack of blood supply, blocking a bit the blood supply to the heart. And that can give premature ventricular contractions in controls. Yes, a lot of premature ventricular contractions, a sort of extrasystole. But when you give oxytocin, it very strongly decreased the premature ventricular contractions. However, at higher amounts, there's a lot of effects. So you should need to remain at the physiological amounts. Don't overdose with this. And when you give an oxytocin receptor antagonist like atosiban, you know this already. Well, you see, you nullify the effects. Also for the ventricular tachycardia and fibrillation, that's extremely dangerous. Ventricular tachycardia can lead to fibrillations. You see that oxytocin makes them at the physiological dose completely disappear, completely. You know a drug that can do that? And, but at higher amounts, again, there's a loss of efficacy. And again, it's also, the effects is also blocked by an oxytocin receptor antagonist. And then I have to say something here, calcitonin. Calcitonin is maybe the forgotten hormone for atrial fibrillation and even ventricular fibrillation. Calcitonin deficient patients look like this. They have back pain. They usually have had a thyroidectomy, a scar. So thyroid tissue has been taken away, and it's in the thyroid gland that calcitonin is made. So calcitonin sufficient patient looks straighter and doesn't have back pain. And so it's a straighter appearance. Calcitonin is fantastic to get rid of back pain. I have treated cases that couldn't be operated, gave them oxytocin. 2 weeks after, the pain got away. Straighter appearance, there's more bone density with it. What is interesting is that calcitonin is a hormone that lowers the calcium level in blood, and it lowers the osteoclast activity, the bone resorption. And in the atrium, it's in the atrium that the pulse is launched for the heart rate. The heart cells in the atrium produce calcitonin. This is a heart cell of the atrium. It produces calcitonin in these little round vesicles. There's calcitonin. And calcitonin receptors are in the kidneys, in the osteoclast, those cells that do bone resorption, skeletal muscle, but also in the muscle, in the fibroblast of the atrial. So calcitonin dominates the fibrous tissue making. So it's wide distribution of this calcitonin. And the key factors, risk factors to atrial fibrillation, this dangerous form of heart arrhythmia, is age. The older you are, the more your risk, and the higher BMI is. Well, these two risk factors are associated with low calcitonin levels and low calcitonin receptor levels. So there might be a relationship here. And the heart cells in general of patients who have persistent atrial fibrillation and rheumatoid arthritis have compared to those who have a normal heart rate and also rheumatoid arthritis have 6 times lower levels of calcitonin. So maybe that's why they have a persistent atrial fibrillation. And dogs have been given arrhythmias, they can do experimentally cause a irregular heart rate by injecting calcium in dogs and rabbits. And calcitonin treatment can block those effects. It lowers the heart rate, it makes the heart pump less, so it calms down the heart beneficially, and it strongly reduces the ventricular arrhythmias, bad beating of the big chambers of the heart. The mechanisms are unknown. That has something to do with the calcium ion fluxes, probably. And what about hydrocortisone treatment? It does improve the heart rate variability. That's another aspect, is that your top physical condition can be determined by checking your heart rate variability. It's the way that you generally, when you have 60 beats per minute, for example, in your heart, it's not every second a beat. There's a small little fluctuations between in the timing. And the more fluctuations are in the timing, the better it is. That means that your heart can adapt to stresses easily. It may not be too rigid and be always with no change in time. This is the heart rate variability. And hydrocortisone actually can decrease the heart rate variability. Not well in healthy people, don't need it. But in an inflamed person where hydrocortisone is necessary, hydrocortisone is beneficial. This is healthy adults. One day before they receive either placebo or a stress dose hydrocortisone was infused, the dose that you would make when you're in an inflammatory state, or pharmacological hydrocortisone, higher than what you would normally make in nature when you're confronted to an inflammation. And then a systemic inflammatory stimulus was given. They were injected lipopolysaccharide, a sort of long sugar or fat sugar molecule that is a sort of toxic molecule that comes from a bacteria, Escherichia coli. And that makes that you get fever and you get inflamed all over your body. Well, those that had a placebo, their heart rate variability decreased by this systemic inflammation. So if you want to improve the heart rate variability, do not be inflamed. And hydrocortisone that decreased inflammation tempered that bad effect on the heart rate variability. But those who received a pharmacological dose even were preserved from a decrease in heart rate variability. So hydrocortisone can keep your heart in good condition when there's inflammation. And so the heart, hello, hi. Can you put your video off? I'll still have 15 minutes to speak. Is that okay? Michel, est-ce que tu peux mettre ton micro out et ton vidéo out encore 15 minutes parce que je n'ai pas encore fini? C'est possible? You know, so heart failure, this is what can we do against heart failure? Well, why do you get heart failure? Michel, l'icône est dans le bas normalement de vidéo que tu devrais enlever parce que sinon tu apparais sur l'écran. So how to prevent and treat heart failure that is caused by hypothyroidism? Because that's a special heart failure that is probably more frequent than we think. You see, for example, this is a patient with severe myxedema. It's a picture of the collection of my great-grandfather, and he made a lot of pictures of his patients. And with thyroid treatment, that's how you become euthyroid, slimmer. And how does thyroid hormones do that in 2 months' time? It takes out myxedema and special waste products between the cells. It also increases the metabolic reactions, so that the heart also cells will be more stimulated and have a better metabolism. So this is a picture of a patient with myxedematous coma. So much low thyroid that the patient lost consciousness. And that is the picture of the heart. The heart, this is myxedema's heart. It's a cardiomegaly. It's a cardiac enlargement showing heart failure. And in autopsy, this is what you see. It's much thicker tissue, you see. It's swollen up with myxedema. The white here between the cells, that is myxedema. And you have here 625 patients with cardiovascular disorder. And it was seen in these patients that the lower the serum free T3 levels were, the higher the parameter of heart failure, the B-type natriuretic peptide was, the BNP. Also, patients with heart failure with low ejection fraction were examined. Those who were in the lowest tertile, the serum T3 levels, compared to the highest tertile, have significantly increased serum brain natriuretic peptide. 59 patients with heart failure with low ejection fraction, lower serum free T3 levels outside and within the reference range. They had an increased NT-proBNP. So the lower the T3 levels are, the most active thyroid one, the more you have this NT-proBNP. And I can talk of special experience because of the COVID vaccine, I had those bad reactions on my heart, and they gave me a certain degree of heart failure that I'm reversing still now. I still need to do some efforts, but basically I recently had a higher level, like 550, which is not dramatic, but basically it decreased already 250 just by increasing my thyroid hormones and also increasing a little bit my cortisol levels that were a bit too low. Here you have patients with acute heart failure, and the lower those who had the low total T3 had that is below the lower reference limit, because the reference range is 60 here and it's below 52, 8.5 times increased all-cause mortality for those patients with heart failure. There's a lot of hormone deficiencies in heart failure. It's one of the important factors to take into account. Here are patients with heart failure. Those who had a low T3 syndrome, followed up during 2 years, had worse heart failure, heavier functional class by New York Heart Association, more dilation of left ventricular arteries, and less heart contractility, and more atrial fibrillation. Now, what I showed you this slide is also this, is that those with low T3 syndrome will do very badly with beta blockers, probably like me. When I took those eye drops with a beta blocker, completely came into a sinus bradycardia, very dangerous, 44 per minute at rest. And so beta blockers at doses of bisoprolol more than 5 milligrams per day, but it's not good, but also watch out for the eye drops with beta blockers. Here you have a placebo-controlled double-blind study with patients with low T3 syndrome, and they were in heart failure, and they received a small dose of T3, 25 micrograms per day during 6 weeks, and they could walk 26 meters better for those, which is better than 67 meters for those who took placebo. And they had a decrease of CRP, and they markedly decreased by 75% their NT-proBNP, marker of heart failure. And they had a 5% increase of left ventricular ejection fraction, just with a tiny dose of 25 micrograms per day of T3. But they had a low T3 syndrome, so they will benefit better from this sort of treatment. So chronic T3 therapy was safe and benefited these patients. What about cortisol treatment in acute treatment? Heart failure, a patient who has low cortisol looks like this. That's before and that's after. She looks better here. There's more energy that cortisol gives, more blood pressure. And I wanted you to show this. The 20-year-old man with a very severe adrenal deficiency and poor gonads, and his serum NT-proBNP is 4,252 picograms per ml, which is a lot. It should be below 125. But he had a good ejection fraction. And he received his hydrocortisone treatment, and that dropped in 2 weeks' time from 4,000 to 338 picograms per ml. 2 weeks later, he was added then testosterone replacement during 3 weeks, and that completely normalized NT-proBNP to 40 picograms per ml, more than 100 times lower. Of course, it's a case report. I know. But but it does give a good idea. And I can tell you that in my case also, it helped to improve the values. There's growth hormone that can be given. We don't have so much time because we're approaching, but growth hormone makes you younger. It tightens your body. When you see this is due to growth hormone treatment. This happens also with the heart and other organs when you give growth hormone or IGF-1. And so this is a woman who had congestive heart failure and growth hormone deficiency. And look, she has a dilated cardiomyopathy and low ejection fraction, 20-25%, while it should be above 55-60%. And there's a dilated left ventricle. It's enlarged on an MRI. And she received glucocorticoids and thyroid hormone with cardiac medication. It helped somewhat, but not enough. But when she started growth hormone replacement, this led that she didn't use those other cardiac medications so much more. They didn't need it so much more. She lowered the doses, and that really improved her parameter. And this was the result. You see here, and this is smaller and more compact. It's a contracted left ventricle and not a dilated left ventricle. So here's a study with growth hormone therapy. It was given during 4 years in patients with chronic heart failure and growth hormone deficiency. It almost doubled their IGF-1 level and increased by 13% the serum NT-proBNP. So not as much as cortisol or thyroid hormones could do it. And but in the controls, the NT-proBNP increased. So it's a better, and it increased by 7 milliliters per kilo per minimum. The peak VO2, the VO2 max, that's a lot because you need to go, an optimal one is above the 27. And it's significantly 10% increased the left ventricular ejection fraction. So if you are at 30 and you're at 40, it's already less heart failure. And so they really improved other values. So really, really interesting. And there are other studies that showed the same efficacy. What about stroke? That's my last, that's the last session in here, but also it's a separate session in the model that I'm showing. There's an ischemic stroke and hemorrhagic stroke. There are two types of stroke. And so the ischemic stroke, when you look at here, is actually a whole zone that doesn't receive enough blood supply. Hemorrhagic stroke, that's just too much blood supply there that fall and that crushes and compresses the tissues. And 20% of strokes are hemorrhagic, 80% approximately are ischemic. And what are the hormones that can protect against ischemic stroke? There are many of those. Melatonin, testosterone, growth hormone, DHEA, and there's really things you can do to reduce the damage or to prevent having stroke with these hormones. Many studies show that. Estrogens also, progesterone, thyroid hormones, coenzyme Q10, vitamin C, there are also blood fluidifying nutrients. So there's a lot of information, too much to give here. But if you're a nutritionist, think about coenzyme Q10, vitamin C, and other antioxidants. They help very much. You can give very high amounts at that moment without danger normally. But there are also blood fluidifying nutrients that can help in ischemic stroke that you may not give in a hemorrhagic stroke, which are fish oils, vitamin E, and magnesium. Magnesium you can give also in hemorrhagic stroke, but I wouldn't give vitamin E and omega-3 because when they're in too big quantities, they increase bleeding. And that you may not give in hemorrhagic stroke, but it's okay here in ischemic stroke. Now, just to show you that testosterone treatment with injections is again this bigger study that we saw already before, and you have not 9 times less risk of stroke. These men who received testosterone injections, of course, these men needed testosterone; they had low levels, but it's amazing how much less stroke there is with these testosterone intramuscular injections. This very large group of about 40,000 middle-aged men. And then now also interesting is thyroid treatment is good, but don't give too much. You see, these are people we treated with thyroxine, and some achieved euthyroidism, which is the state being normal in thyroid. But if there was still too low dose given, there was an increased stroke risk. If the TSH was above 5, there was 25% more stroke risk. And exogenous hypothyroidism, when there's too much thyroid hormones, also not good. If the TSH is below 0.1, there was also 33% increase in risk. So what to conclude is that you need to be just in between the two. And for estradiol treatment, the use of estradiol and dydrogesterone, which is almost a natural progesterone, decreased the thrombotic stroke risk, the ischemic stroke, by 50%. But there was then, but other types of HRT increases thrombotic stroke. So choose the right ones. Choose transdermal estradiol and oral progesterone or dydrogesterone, and you're safer. Okay. Before I get to give you some other information, we're going to join with Michel de Lorgelil. Michel, est-ce que tu es là? Est-ce que tu peux réapparaître sur l'écran? I will stop sharing my screen. And I don't know if Michel de Lorgelil is there. He was there. Michel, can you join the panel? Okay, if I don't have him, I'll go directly with some information in the meanwhile. I don't know if my team is active there to try to get Michel back on screen. Michel, he doesn't look to be in the gallery, so I will continue then. Just a moment, I will try to see if my team can get Michel back. Okay, what we'll do is that we'll start the question and answer session now, but I'm going to give you some information about the promotion. Just a moment. I will try to get back. Just to tell you that there's also a special offer with this webinar and all our educational material. And I repeat, for those who have not assisted others, there's Reversing Physical Aging, which is very informative with a lot of references on everything you can do to age less in the face, in the hair, and the senses. The Hormone Handbook is really the bestseller in guideline and how to do hormone therapy for 18 hormone therapies. Really interesting with all the information you really know how to make it safely and efficient for your patient. Also, the Atlas of Endocrinology for Hormone Therapy gives you all the symptoms and physical signs. And then there's also one of my favorite books, Testosterone. I like this treatment. It's a therapy for real gentlemen and certainly not for violent people. We have also an e-learning program, the hormone therapy consultation, adrenal hormone therapies. It's each time a model with sessions of about 2 hours, full in details on how to do it. And I really think that this cycle 2 is extremely interesting. If you want to start with hormone therapy, this is the one you have to take. This really gives you a lot of information so you can start. Even for advanced people, physicians, they will learn a lot. There's adrenal hormone therapies, growth hormone therapies, IGF-1, psychological disorder, absolutely fascinating for me. I've updated a lot the information. Longevity, very interesting in our time now. Sexuality, I gave the webinar on it, and cardio and cerebral vascular disease and obesity. In the next events to attend, I will be talking in a Canadian conference online with Nelly de Vest about melatonin and topical melatonin, how to can rejuvenate. And then there is an inflammation workshop that I will give on the AFRAM in Orlando, May 18. And you will see a lot of information on how lifestyle therapies, nutritional supplements can help decrease inflammation. And of course, a whole afternoon of hormone supplementation to reduce inflammation. Est-ce qu'il est là? Je partage pas l'écran ici. Oh, it seems that you don't see what I'm showing. And I'm just going, okay, and just a minute. Okay. We'll interrupt here and we'll interview Michel Delorger. Michel, est-ce que tu m'entends? Do you hear me, Michel? Michel, oui. Do you hear me? Do you hear me? Okay. Michel, I hear you. Do you hear me? You're on screen. Michel?
Hello?
Do you hear me? Do you hear me? I don't hear you. Can you speak? No. You have to put your audio on. The audio is in the left corner down. The left corner down, you have to click your audio on. Left corner, audio on. On n'a pas fait d'exé avec. Michel, I don't hear you. You have to put your audio on. You have to click on an icon or microphone. It should be on the left corner down, please.
Now it is working?
Yeah, it works. Okay, perfect.
Oh.
Okay. Okay. Michel, we'll talk in English. This is okay for you?
Okay.
Okay. So, Michel, I first have to thank you. I have a great admiration for your work. I already gave a little slide in the beginning about what we're doing. And I think many people are excited to hear from you. I'm going to ask you our first question. Michel, what do you think about statins? Is it justified when you have to decrease your cholesterol to take a statin? Is it beneficial or is it dangerous?
Statin is the most famous cholesterol-lowering drug. And it has been claimed that by lowering cholesterol, we can reduce the risk of cardiovascular complication, right?
Right.
But in fact, after maybe 40 years, it seems that most clinical trials testing statins have been flawed. And now the independent scientists, I mean scientists independent from the industry, are thinking that statins are not efficient to decrease the risk of cardiovascular complication. And as a consequence, we can say that probably cholesterol is not a cause of cardiovascular complication.
So what would you advise if people have a high cholesterol? Do they have to do something on their diet or not take a statin, I suppose, because there's no science that really backs it well up? But what would be your advice for them to lower their cholesterol?
Well,
or to optimize their cholesterol, because it's not a cause of cardiovascular disease?
No, it is not the question. For us, as cardiologists, independent from the industry, the question is, what is your risk of cardiovascular complication? Not what is your cholesterol. In fact, we don't consider cholesterol level. Even in familial hypercholesterolemia, we think, as a group of scientists, we think that it is not a cause or even a risk factor. Thus, if a family or a patient asks me what I have to do to decrease my risk of cardiovascular complication, I have to do the work. What is your risk? Independent from cholesterol. And as you know, there is a genetic predisposition, not cholesterol, genetic familial predisposition, and there are the lifestyle. the two issues we have to consider, but it is a lot of work.
But I went into consultation with you and I was very amazed. You were looking at a lot of different parameters, not the cholesterol, but you were looking at other parameters that were important for you. Which are these blood parameters that you think are important, should be checked by doctors and by cardiologists?
First, lifestyle. Then we try to build a genealogy tree to see whether in that specific family there are people with who are survivors of a stroke, ischemic stroke, or an acute myocardial infarction. When there are people in the family, the father, the mother, the brother, the grandfather, and so on, and when there is suggestion that there is a family risk of cardiovascular complication, we must understand why there is a risk. It is not cholesterol, but there are many other factors. And at present, we think that the coagulation factors are the main cause or risk factors of cardiovascular complication. And once you have identified which coagulation factor is in question, you can decide which kind of treatment, I mean, drug treatment, should be the best for this patient. And then there is the major issue of the lifestyle.
So we'll go to lifestyle afterwards, but what is for you, some of those important factors? Is it the homocysteine or lipoprotein A, or what exactly?
There are many, but in my own experience, some factors are more important than the others. The first one is a lipoprotein lipase. This is, in my experience of epidemiologist, most people with a cardiovascular complication, MI, acute myocardial infarction, or ischemic stroke before the age of 50, 55, usually they have a high lipoprotein lipase. But some other factors are very important too. For instance, fibrinogen. There is a connection between the genetic predisposition, high fibrinogen, and the lifestyle. For instance, high fibrinogen is very dangerous among the smokers. Now, some other factors are very important. You say homocysteine. There is, when you have high homocysteine, it can be a genetic predisposition because some enzymatic systems are not well functioning, but there are also the diet. The diet is very important also. The connection between genetic predisposition and lifestyle. Then you have some factors that are not well known by the medical doctors. For instance, albumin. Having a low albumin level is very dangerous because albumin is an antiplatelet agent. It's better than aspirin, for instance.
Oh.
Four different factors. Then you have to go to the coagulation system, and you have antithrombin, and you have protein C, and you have protein S, and so on. Then you can look for mutation of some protein of the coagulation system, and the two main mutations we look for are those about factor V, it is a Leiden mutation, or the factor II, prothrombin factor, and so on. And we can scan.
Okay, because so what would be for you is the lifestyle just what sort of food would you propose, for example, for lifestyle? what would be a better food that protects against heart disease?
Well, in lifestyle, the dietary habits are very important. I put it at the highest level in terms of risk. But some other factors are very important too. For instance, smoking. For instance, the lack of physical activity. For instance, the profession, the job, the way you work, the way you feel your job, the way you suffer your job is very important. And also
you would promote a good feeling that when you do your job, you do it with a good feeling. Otherwise, it's not a good job or it's not a good way to do.
Also, the family life is very important. The couple life. You know, among my patients, some family stories are awful. You know, divorce. Some children were sick, or Alzheimer in the couple, and so on. And this is very difficult for a person. Now, regarding the dietary habits, this is a critical issue. And we do not think in terms of nutrient or in terms of foods. We reason in terms of whole dietary habits. And I know you know that I am a promoter of the Mediterranean diet. This is the critical issue. Many people think that, oh, I am using olive oil for my salad, and no, olive oil is one very small aspect. I don't eat butter. It is not enough. If you want a small piece of butter for your breakfast, why not? But you know, it is the whole dietary model which is very important.
It is, for example, there's a lot of fuss now about intermittent fasting, that we should not eat too often or too much. Could you combine intermittent fasting with Mediterranean diet, and that would probably be the best option, or you don't think that fasting is good? Because I think there's a study on low-calorie diet. When people go on low-calorie diet, they decrease their inflammation by 80%, like CRP, 81% decrease. So do you have any suggestion on that fasting could be good, or?
As you know, I am a scientist, and I have no belief. I just look at the data, and robust data. If you ask me about fasting, I will answer, do we have a clinical trial testing fasting, not in terms of CRP or cholesterol or blood glucose, but in terms of cardiovascular complication? At present, we don't have. We don't have. You can also cite the ketogenic diet. Yeah. Many nutritionists like the ketogenic diet, but you know, people were saying this is very good for your blood glucose, for your weight, and so on. But there is only one study investigating the relation between ketogenic diet and the risk of cardiovascular complication, and there is a highest risk of cardiovascular complication among those following the ketogenic diet compared with a prudent diet. You know.
Yeah, I think there's even pictures showing that it's indeed not good for this cardiac ischemia and other things. There are some data with but it's only animal data. So animal data of experiments on animals with intermittent fasting that showed that there was less, I think, cardiovascular disease, less cancer, less longer longevity and things like that. But unfortunately, there's no industry behind it. So there's no data on, or not much data on humans. They're in the making, but it's maybe still too early. But I think what I really mean is that studied the centenarians, and centenarians also eat less than other people. Would you also recommend not to eat too much when there's cardiovascular disease, or you wouldn't mind whatever they eat? The quantity is not important. It's the choose of food.
I'm very sorry. I will answer. I don't know. I cannot answer. The only dietary model that works, and there are so many studies about the Mediterranean diet. I think that definitely the only model for me is the Mediterranean diet. I will give you one example about homocysteine. We have discussed high homocysteine level due to dysfunctioning of enzymatic system. I will not give details, but at the same time, if you don't have a correct diet, also homocysteine can increase. But so many nutrients are potentially involved. You know, vitamin B6, vitamin B9, vitamin B12, beta, and so on. And it is impossible to reason in terms of specific foods. You have to take a whole diet to decrease homocysteine. Is it clear?
Yeah, so what you would propose is that you improved your diet, and that's it. The quantity is not important, or you don't know, and but you need to.
No. The quantity is important, but you cannot give general rules for the population. You know, if your weight is 120 kilos, and if you are working outside all the day, you are completely different from a young woman, 50 kilos, and working in an office all the day. You know, the quantities needed are totally different. It means that for me, we have to adapt our dietary counseling to each person. This is
personalized medicine.
Medicine, exactly. Thank you very much.
I'm going to ask you a little bit more about, so you talked about people having trouble in their family, at their work, not a good situation, feeling stressed. That is not good for cardiovascular diseases. How do you change that in people? Can you make people feel better? Because what I think is feel better. Can you make the people feel love more, feel in love more, have more love relationships? That would be a solution. How do you do it?
You know,
there's no science probably, but anyway, I'm asking you the question.
No, there is some science, but you know, I am a cardiologist and I am a nutritionist. But you know, managing people suffering because of their job, it is not my job. I have to refer to other people. I can advise. I have some connection in my environment, and I can tell them, go to this person, try yoga, or try more physical exercise. Or there are so many advices, but in fact, to help people in a difficult work context, it is really a specific work. It is not my job.
It's not your job, but I know you do make people realize that, so that they think and they might go get help. So your job is maybe to be a little joint between the helper and the person in distress.
This is a very important aspect. You know, of course, I know how you work, but so many conventional doctors are so stressed, you know, and they don't have time to listen their patient, to give time to the patient to say what is their suffering. And I take time, and often I take a long time to have a long family or a long couple history. And it is so good for the people at least to say, to be listened.
Yes, I think so. And I think that's a great job that you do by listening to their suffering. They start healing already. Now, you did also work on omega-3. Can you comment about that? How would we get the good omega-3? What is good?
Omega-3 fatty acid, this is a complex issue, because when you talk about omega-3 fatty acid, many people think about marine omega-3 fatty acids, a very long chain omega-3 fatty acid. I mean, eicosa pentanoic acid and docosahexaenoic acid, EPA and DHA. But probably the most important one is a plant omega-3 fatty acid called alpha-linolenic acid. Just to give you an idea, in the Mediterranean diet, the intake of alpha-linolenic acid is about 3 grams per day. In the same time, the average intake of EPA DHA is less than 1 gram. In terms of quantity, it is quite different. Then, alpha-linolenic acid is a source of EPA and DHA. We are able to make EPA and DHA from alpha-linolenic acid, in particular in the brain, in the neurons. This is a very important point because alpha-linolenic acid, you eat it and it disappears from the blood very, very fast. But if you make experiments in animals with radioactive alpha-linolenic acid, you find the carbon, the radioactive carbon in the brain. In the brain, in the form of EPA and DHA, which are very important for the neurons, but also under the form of cholesterol. And as you know, brain cholesterol is so important. But to make your, there is a barrier between the blood and the brain. It means that your cholesterol in the blood doesn't go to the brain. The brain has to make its own cholesterol. And the main source of carbon to make cholesterol in the brain is alpha-linolenic acid.
Wow, that's interesting. I never knew that.
This is the work done by Canadian investigators. Oh. Maybe you know Cunan. Cunan, the group of Cunan in Quebec. Well, now, the story of omega-3 fatty acids is very complex because I was a participant in the story at the beginning because with other investigators in UK and in Italy, we have demonstrated that when you give omega-3 fatty acid to people at risk of cardiovascular disease, you can decrease the risk of cardiovascular disease. The studies in UK, in Italy, and in France, my own studies were very different, but at the end of the day, we together concluded that the main thing is not to be insufficient or deficient in omega-3 fatty acid, alpha-linolenic acid, EPA, and DHA. But it is not useful to have too much omega-3 fatty acid. And after our discoveries of the importance of omega-3 fatty acid for the prevention of cardiovascular disease, of course, industrials came to propose capsules of omega-3 fatty acid. But of course, if you are an industrial and you think that omega-3 are medicament and not nutrient, your goal is to sell more and more every day. And to sell more, you have to increase the dosage of omega-3 in the capsules. And it is a sad story because industrials paid investigators to test high dose of omega-3 fatty acid, essentially EPA and DHA, in patients at high risk of cardiovascular disease, especially in patients at high risk of sudden cardiac death or in patients with chronic heart failure, or in patients with high risk survivors of a previous myocardial infarction. And all these studies failed. Giving high dosage of omega-3 fatty acid was not good for these patients.
I saw that some studies used 4 grams and they had a higher mortality because it was just too much, probably. Because
this is the most recent studies, but it is the second chapter. I am talking about the second chapter, but there is a third chapter where most cardiologists stop to prescribe omega-3 fatty acid to their patients. And the fourth chapter, a new wave of interest for the omega-3 fatty acid with new industrial, for instance, Amarin in the United States, and they proposed synthetic omega-3 fatty acid, in particular synthetic EPA, and they proposed to give high dose of EPA up to 4 grams, as you say, because their theory was that omega-3 fatty acid are useful to decrease blood triglycerides. They were thinking that despite statins and low cholesterol level, their patients still have MI and stroke. It is called the residual risk. And they were thinking that the residual risk was due to triglycerides. But we do have drugs to lower triglycerides. You remember fibrates, clofibrate, fenofibrate. But these drugs are able to reduce triglyceride, but they have no effect on the risk of cardiovascular disease. Therefore, Amarin and some scientists, medical doctors, university professors, essentially in the US and in France, propose high dosage of omega-3 fatty acid to decrease triglyceride, and they hope to decrease the risk of cardiovascular complication. Well, the main study was called the REDUCE-IT trial, and they gave 4 grams per day, and the sample size was huge, 8,000 people. The follow-up was long, 5 years, and of course, the study was conducted by the employees of the industrial. The methods were not good, and at the end of the day, there was a very small effect on the risk of myocardial infarction and stroke, but no effect at all on mortality.
Okay, so not so worrisome. We're getting now a bit out of time, so we're going to have questions of the audience. And I'm first going to show some people who will help us sponsor so that you have information. And then, so I will share my screen, and then I will, if you can stay online, Michelle, so that you can answer also questions from the audience that there will be, because we already have a series of questions. So let me share my screen again. So you see, just to tell for people who are following me is that I have a webinar in Canada on Monday in May there. It's the 15th of May. And there is also, I will be at the EFRAM Congress, as you see here, which will give on inflammation on, with a lot of very interesting information on how you can decrease inflammation, also by meditation, by reducing your stress, physical activities, but also nutritional and hormone supplements. And you see that we can do a lot against inflammation. On the main session, I'll talk about also the hydrocortisone and DHA effects, how you can make that safe to people who need those hormones so that you reduce inflammation. And I will also have a little workshop in the evening on treating adult hormone deficiencies, growth hormone, testosterone. And I will be in November in the Congress in Mexico for a workshop on optimal hormone therapy with a lot of practical things on what is typical to men and women, how you can treat this, not only with hormones, but also nutrients, and very interesting. So that will be in Mexico, the 17th and the 18th on typically male and female health. And I will be also in a congress in Ghent in Belgium on hormone balancing, how it can affect psychological illnesses as depression, pathological, and anxiety, and how can reverse that. And then AFRM Congress will be there, etc. And there will be also access labs on the AFRM conference there. So many conferences. I just want to thank all my partners here that help us to send the movement. They do a lot of good job. And I'm going to let one of those partners and then the second one talk, and then we'll have the questions. So please stay on.
Je me présente. Anne Serrault, directrice de Vital Plus, notre entreprise familiale fondée par mon père en 1987. Nos installations éco-conçues sont implantées dans une zone verte dans la Sarthe, en France. Depuis plus de 35 ans, nous formulons, fabriquons et distribuons une gamme complète de formules innovantes et exclusives, dont 90 sont certifiées bio. Nos produits sont purs, sans additifs inutiles, concentrés de façon optimale en actifs d'intérêt, objectivés par la science. Nous choisissons chacun de nos ingrédients nutraceutiques et garantissons leur qualité nutritionnelle, leur efficacité, leur biodisponibilité, leur sécurité et bien sûr leur naturalité. Depuis les premiers jours, notre expertise s'est concentrée sur la prévention, les piliers de la longévité et la nutrition cellulaire, le tout associé à de fortes valeurs qui nous inscrivent dans une logique de développement durable. J'espère que vous aurez envie de découvrir notre marque fabricante, engagée pour le bien vieillir et la longévité en bonne santé. Merci à tous pour votre écoute et n'hésitez pas à nous contacter si vous souhaitez plus d'informations sur nos produits de santé naturelle.
Just a little word here on Vital Plus is that I was on a TV program on longevity on the Belgian TV this Monday ago, and actually had a lot of success, but they were talking about several substances like senolytic to live longer, and they already are developing senolytic, but not with the science and meta-analysis yet. But it's interesting, they're always very, very sharp on the point, so very interesting firm. And then you have here also Pharmanor, who are have done several experiences that are really worth showing. They're showing that supplements do work, placebo-controlled studies.
Topic of today will be Q10 and selenium. Some years ago, we had a very important study, the Kiesel 10. It was a study, 443 healthy subjects in Sweden were followed for more than 5 years. The study has been done by Professor Allerhagen, who is a worldwide specialist in Q10 and selenium. The results were quite something, because we saw that in the Q10 and selenium group, we had even a better heart function. 1 year ago, there was a study in Q10 and selenium with the telomeres, and we saw that the preservation in the active group of the telomeres was a lot better than in the preservation of their telomeres in the placebo group, what is quite a result. Only 1 month ago, next study about SIRT1. SIRT1 is an enzyme that decreases our cellular aging. But with increasing age, the levels of our SIRT1, that enzyme, will decline, because our cells are aging. But what was really interesting is that the scientists, they discovered if we gave Q10 and selenium to those healthy subjects, that we could see that their SIRT1 levels of that enzyme increased with 35%. The function increased again. In the placebo group, SIRT1 levels went down, which is normal because their cells were aging. This could mean that you really could have an impact on the aging of your cells. So on top of the benefits on the energy level, Professor Mitchell won the Nobel Prize for his discovery that Q10 plays that important role in the energy production in every cell of the human body. You can have the benefits on the telomeres, on your telomeres. You can have the benefit of the SIRT1 or on your cellular aging. Quite something. Pharmanor is globally the specialist and the reference in Q10 and selenium. So if you want to age in a better way, in a healthier way, try to move more, eat healthier, and if you need some supplements, I think Pharmanor is a really good choice for you. With a proven track record of more than 400 trials who has been done on our products. So if you have any questions, don't hesitate to contact us, and thank you very much and have a great, great day.
Just a little word of Joe Klaas, he's the director now, I think, of Pharmanor. in Belgium, and they always are making placebo-controlled studies. So I think this is very interesting to have a firm that does placebo-controlled study with efficacy. Was very impressed by their mixing of 200 micrograms of selenium and I think 100 milligrams or 200 milligrams of coenzyme Q10 that showed also lesser mortality. So let's go, and useful addresses are this if you want to contact us, office@hertoghe.eu, and then the website hertogmedicalschool.eu, where you have all the information. Now let's go to the questions, and I'm going to stop sharing my screen here with this, and I will look at the questions here. Let's go maybe at the end first, because there will be more questions for Professor Longeville. What are your recommendations for someone with a high lipoprotein A and a high LDL cholesterol? Michel, can you answer that?
Yeah. Regarding high LDL cholesterol, I don't care. In contrast, it is impossible for the moment to decrease lipoprotein little a levels. You can have some fluctuation of the levels in function of various parameters, but when the lipoprotein little a is very high, there is no way to decrease it in a significant way. For that reason, our strategy is not to decrease lipoprotein little a, but to neutralize the effect of lipoprotein little a. It depends of each patient. We can select anticoagulant drugs or antiplatelet drugs. It depends of the clinical profile of the patient. For instance, if the patient is surviving of a myocardial infarction, he had a stenting, we prefer giving antiplatelet drugs. But in case of stroke, ischemic stroke, we prefer anticoagulant.
Okay, good. I have to give a little different opinion, is the fact that I did find studies that showed that thyroid hormones decrease lipoprotein, that testosterone might decrease. We know we had a discussion on that. And so I do think there are some important information, but you should avoid growth hormone, because growth hormone seems to increase lipoprotein if you have a high one. Although I take growth hormone, my lipoprotein was in the times 93, very high. And it's down to 60 with what I take. It's not a big difference, but it is a difference. And then what is the best calculation for omega-3 administration? And for how long is okay to administer this metabolic balance with HBB? I don't know what that is, fat liver and mixed dyslipidemia. So, but you would not suggest omega-3 administration, or you would suggest alpha lipoic acid, or what would you suggest, Michel?
We do not reason in that way. It depends of the person. As I told you, if your weight is 100 kilos, it's completely different. You need a nutritionist, and the nutritionist will adapt the dosage in function of the weight, the age, and the physical activity.
Okay, good. Here's a question that is probably for me to answer. What do you think about using 3 months of growth hormone and 3 months off? I think it's better than not using growth hormone, but when you take a hormone treatment, it's always better to take it every day in a small dosage than a higher amount during 3 months and then stopping. The glands do not age quicker because you give every day the hormone it is deficient in. On the contrary, when you give a hormone treatment, the gland that is overworking, is not producing enough because the person is in hormone deficiency, will calm down and will tear and wear less often. The studies in animals have seen that if you give, for example, enormous dose of testosterone at the beginning of life of a rat and at the end of the life of a male rat, you stop it, the testicles start again to work, and they work as good as testicles of a young rat, which is not normal. So it seems to preserve. Same thing with thyroid therapy. Here's a question for Dr. Delorgeril regarding omega-3. What is the lab parameter you are monitoring, and how often? Are you checking omega-3 fatty acids in the blood, or what lab test?
No, it is too complicated in everyday medicine to make to measure omega-3 fatty acid in the blood. You can do it once a year, maybe, but it is quite expensive. It is not covered by the social insurance. But you know, the most important thing is what you eat. Once again, it is the nutrition is the most important, and the way we calculate the true intake of omega-3 fatty acid from plant, from fish, or from other sources, and rather than the level of omega-3 fatty acid in the blood or in the red cells. Of course, if you suspect a deficiency, you have to measure omega-3 fatty acid in the blood, not in red cells, because, for instance, the level of alpha-linolenic acid in red cells is very low and do not represent the real mass of alpha-linolenic acid in the body.
So interesting. So it's blood fatty acids, not the red blood cells.
In the plasma.
In the plasma, okay.
In the plasma, but it is much more complicated for the lab. You know, when you take blood, you can concentrate the red cell, and then you send. With the plasma, it's different. It can be contaminated by the red cells or by the platelet, and so on. And it means that the blood sampling should be perfect.
Okay, so it should be done probably not on a distance too far, but near the lab, so it can be analyzed quickly.
And the sampling should be perfect.
Okay, just this. It's a question for Dr. Delorgeril, but the person doesn't say question. It says just fantastic concept regarding dyslipidemia. Many thanks for sharing your knowledge. So it's rather a mercy. Yeah? Dr. Delorgeril, we know that grains are anti-human food. They are inflammatory, very acidic. The pancreas makes few digestive enzymes for that, creates a lot of free radicals. I'm talking about the grains, the bread and things like that, have a lot of sugar, carbohydrates. Much of them are transgenic, lower the metabolism, lower many hormones, damage the immune system, etc. How is it possible to consider that Mediterranean diet is a good option if it includes grains? What would you say about the grains that are not sprouted? Like bread?
Well, there is, yes, I understand. In fact, there is no science about that. When there is no science about that, and a family or a patient asks me what I have to do and so on, I answer, what the Mediterranean do. You know, the Mediterranean love cereals, love grains.
Yeah.
They eat grains, but they eat, you know, antique grains. The true Mediterranean, because now, if you go in the Mediterranean city, in Roma, in Milan, they eat fast food. But the traditional Mediterranean eat wheat. They eat wheat in Italy, for instance, for the pasta, specific wheat. It is not the same wheat to make the pasta and to make bread. And it is much better to eat old wheat to make bread. But, you know, if you go to the supermarket, you will not find that. You have to look for specific wheat to make your bread. Yeah.
Okay, well, there are studies on longevity that when the people came from the Paleolithic to the Neolithic, there was a loss of 10 years of life on average Once people lived to 15 years, they could live to 55 years. In the Paleolithic times, a long time ago, in the cave history, the hunting, and they died, and they were also smaller when they start to eat grains and civilized foods that we have. But of course, it's indirect evidence. It's not a meta-analysis of placebo-controlled studies. But anyway, it's in French, but I'll translate for the public. We have the impression that statins reduce cardiovascular events and have anti-inflammatory effects. They say that statins help because they're anti-inflammatory. What do you say about that, Michel?
This is just kidding, you know. This is a joke. You know, if you need an anti-inflammatory drug, well, take ibuprofen. If you really you are painful, take ibuprofen. But if you take statins, maybe you will get pain.
So it doesn't really work as an anti-inflammatory. Yeah.
No, it is a joke.
It's a joke.
You know, it is just a commercial argument because there are different steps in the history of statin. I'll give you one example. At the beginning, when they give statins, they pretended a miraculous result, but it was wrong. Any independent doctor sees that his patients with statin can have recurrence of MI or stroke. Therefore, they were thinking that statins could be effective at high dosage, not because of cholesterol lowering, but because of anti-inflammatory effect. But this is just a joke. It does not work.
It does not work either.
No.
Okay. That's probably a question for me. Is it safe if we give testosterone undecanoate injection therapy for acute ischemic stroke patient with low testosterone level with or without sleep apnea? I think any testosterone injection can be helpful for stroke. So I tried it. As soon as the patient has stroke, we increase the testosterone, and we have very good results, even in women. Although I would prefer, it works better, testosterone enanthate injections are cypionate. Those have a 10 days to 14 days action, and they seem to give better results. But anyway, testosterone enanthate injection, 1,000 milligrams, that's the Nebido, is available and won't harm. So you've been sure you will save a lot of people. Now, somebody says if my books are in digital format. No, they are unfortunately not in digital format. Here's a question: how I will titrate the dose of levothyroxine therapy the patient with hypothyroidism with ischemic heart disease? Very slowly, always slowly. Thyroid hormones, when the person has myocardial infarction and person hypothyroidism, I wouldn't give thyroid hormones for 2 months. It's the method of Dr. Broda Barnes, an expert in thyroid function, and he waits 2 months, and then after 2 months, you very slowly increase, 2 times slower than another person. So if you give 25 micrograms every 10 days, you would give 25 micrograms of T4 every 20 days, and then increase the dose slowly. In heart patients are very sensitive for thyroid hormones. So you have to be very, very safe here. Question for Dr. Delorgeville, but
it will be Thierry.
Yes?
It will be the last because I have to leave now.
Okay, you can leave now. It's a very quick. What is the minimum right HDL cholesterol in your blood? Do you look at the HDL cholesterol that can improve with the diet or not?
No. You know, the idea that just back. The idea is that there is a good cholesterol and a bad cholesterol. This is just a Walt Disney story.
Okay.
It's a good cholesterol, bad cholesterol. HDL is good, LDL is bad. This is when you know physiology of lipoprotein, exactly the opposite. I think that the concentration of cholesterol is not important, except if it is too low. Definitely, when you have a very low cholesterol level, it can be dangerous in terms of cancer risk, in terms of depression, in terms of kidney function, in many complications associated with a very low cholesterol level. You have some genetic disease with very low cholesterol level, and these children are not healthy, definitely not healthy.
Oxidized LDL cholesterol, is that matter? They say that the atherosclerosis starts with oxidation of LDL cholesterol. Is that also a joke, or would you rather have a low level of oxidized LDL cholesterol?
This is a very interesting question, because many investigators during the 20th century were thinking that the problem is not cholesterol, but oxidized LDL. And for that reason, they conducted many studies with antioxidants. Some investigators tested the vitamin C, other investigators tested vitamin E, other carotenoid, other, so many at various dosage. All these studies failed to show benefits for the treated people.
So
antioxidant is not a good theory.
So if a person has a high level of antibodies against LDL cholesterol, oxidized LDL cholesterol, that's not a good test, or you don't know much about that?
We don't use it. This is not useful. And in the university hospital, even in people who think that cholesterol is dangerous, they abandon this kind of dosage. We don't use it.
Okay, so it's not helpful. Okay, well, thank you. Thank you, Michelle, being here. I think you had a lot of questions, so it's very good. And I think continue your good work.
Thank you very much.
You are doing and you're making people think. That's also very important.
Thank you very much for your invitation.
I know also that you make people feel differently, so that's also good. Bye-bye. Bye-bye. So you just close your video and your audio if you want. And I will continue answering some questions. Okay, perfect. I will continue some questions, not all, because it's also getting time. What is your favorite application of oxytocin nasal spray? I think there's actually only one really that has a lot of studies, enormous, more than 400 placebo-controlled studies, and that is the syntocinon of Novartis, and that is 8 international units per spray. So that is the spray that we use, although I personally take a sublingual form compounded in a San Diego pharmacy that works even better for me, because I don't respond to intranasal oxytocin. But if you cannot have that, you can have officially in pharmacy, normally the intranasal syntocinon spray. They have also syntocinon injections for delivery. It's the same name. It's also oxytocin. That's on 10 units injections. But so it's the same firm that makes it too. What is HRT? HRT is generally a treatment with progesterone, estrogen, and estrogen together. It's hormone replacement therapy, but it's generally female hormone replacement therapy. So you generally have the 2 hormones, except in women with hysterectomy, it's often then only the name for estrogen therapy alone, although I think you always should give the 2 hormones. How to supplement with DHA in men if there's already a slight excess of estradiol, and would DHA raise estradiol and SHBG? The DHA can convert into estradiol. It converts actually in estradiol in the intestines when it's absorbed by mouth. So if you want to decrease the absorption, the conversion of DHA to estradiol, you can take it sublingual. But then you have to take it twice a day. If you take it oral, it's once a day, because it becomes a lot of DHA sulfate in the liver. Regarding calcitonin, what product to prescribe? Lab test to monitor is more the calcium. The calcium decreases with calcitonin, may not be too low. And calcitonin, it's getting out of the market. So there was an intranasal form that is almost in no country anymore available. And they had several names. Recently we had Miacalcic now I think we still have myocalcic injections for normal intramuscular, but it can also be used subcutaneous. So I use them subcutaneous. And what are main symptoms of calcitonin deficiency and overdoses of treatment? Well, you should read my book. I have a book on all the hormones with the symptoms deficiency, but basically when your calcitonin deficiency is a long time, you start to get osteoporosis, so both back, and you can have problems of getting higher calcium in your blood. And if you take too much calcitonin, you get nausea, so you can not want to eat anymore, and you feel a sort of malaise, fatigue, and things like that. And so you should be also careful. That's why you always start calcitonin at a low dose of 25 international units every 2 days, then every day, then 50 units a day, and 75 to maximum of 100 units a day. Generally, if you do it for long term, it's just 25 international units a day. It's really interesting, this calcitonin. I think I'm going to use it myself here. What is interesting is that probably a symptom of calcitonin deficiency is atrial fibrillation. And then what is the maximum of thyroxine a day? That depends on the patient. For some, 100 micrograms is too much. Generally, you need to go over the 100 micrograms in most people, but the maximum tolerable is maybe 300, because some people do not convert T4 to T3. I even heard about people having 400, 350 micrograms. So what you need to watch out is not getting overdosed with overdose symptoms. What are your thoughts on pellet therapy for cardiac problems? I think for chronic cardiac problems, pellets are good, but in emergency, you need a transdermal, or you need even more injectable intramuscular injection. So it's more for chronic cardiac problem. A person who has coronary heart disease is typically a person who has heart failure also, but you need to start low in the beginning, because once it's in your body, it's difficult to take it out if you give too much. And if you get overdosed, it can convert to estradiol, and there's several other problems. Both peptide therapies, growth hormone-releasing hormone, growth hormone-releasing peptide therapies, produce similar results as growth hormone. I'm not sure. Generally, you have two receptors for stimulating growth hormone. And so growth hormone-releasing hormone just works on one receptor. So you are better to give growth hormone, and maybe you can give additionally the other ones, but to get more stable results, it's better to give growth hormone. Yeah. So here's a question about DHEA, and I'm not sure there's initials. I don't like initials, HTA, so probably hypertension, or is it heart failure? I'm not sure. But DHEA is important, but it's not as efficient as testosterone, thyroid hormones, or growth hormone to reduce heart failure or blood pressure. It is mostly important in people who tend to be very stressed and have hypertension or have heart problems because of the stress, because DHEA blocks the bad effects of too much cortisol. So DHEA is always given in cardiac patients, but it's not the main treatment in them. And then I'm probably going to do one or two last questions. Do you recommend any estradiol patch available in the European Union? Do you recommend estring for vaginal estrogen? I don't know about estring. I suppose it's vaginal estrogen applied. So I cannot really comment. There are studies that show that vaginal estrogen are very protective, even more than transdermal, I think, for stroke. So it means that you really have the 65% less stroke when estrogen is given as vaginal rather than a transdermal. But that's the only study I saw that made a difference there. And so an estradiol patch, I don't propose transdermal estradiol patch. Why? Because the first day you have too low dose. Second day, it's too much. Third day, it's too low. So it's much for patches you give 2 times a week. You cannot put the adequate amount of progesterone to calm down estrogen predominance. So it's better to give a transdermal every day that you apply on the shoulders, full arm on a large distance, and then a pump, and then a second pump here is actually better. You give that in the morning and progesterone in the evening. And here, which age hormone replacement therapy is good for a woman's heart. Why is there an association with varicose veins? What helps varicose veins in postmenopausal women? So first of all, the best hormones for the woman's heart are transdermal estrogen and bioidentical vaginal or oral progesterone. And in my model, I explain exactly how to dose and how to give it, etc., depending if you're in the premenopause or postmenopause. Why is there an association with varicose veins? The association is due to relatively higher estrogen levels and relatively lower testosterone and progesterone levels. So in order to, once you have varicose veins, generally you cannot reduce them. I do have some women who have put testosterone on the right direction from the feet to the pelvis, and they applied testosterone and they seem to have less varicose veins thanks to the testosterone. But I couldn't generalize this concept. So what you need to do to avoid further development of varicose veins is to have a lower dose estradiol and a higher dose testosterone or progesterone relatively. So you change a bit the balance, slightly lower estrogen, slightly more progesterone and or testosterone, and then that there's any sign of estrogen predominance. Swollen breast, swollen belly, nervousness and things like that. If you don't have that, you're calm and you don't swell up, it's much better this way. And that's the way to avoid it. And the last question that I will take, thank you, Dr. Hertoghe, I would like to ask if thyroid therapy can help in hypercholesterolemia in women with normal TSH and thyroid function. The hypothyroidism is actually decided on clinical findings, physical exam, physical signs, on symptoms and lab tests, but not only lab tests. And the lab tests are not tests that shows you if a person is hypo or hypothyroid. People are within the reference range can also have hypothyroidism. It can be low normal in thyroid hormones or high normal in TSH and have a thyroid deficiency. And I have a lot of studies. I think there's more than 150 studies now that have been published that show you that thyroid tests within the reference range are linked to more pathology depending on the level, a low normal level of T3 or T4 or a high normal level of TSH. So I have a lot of patients that are treated for hypothyroidism with lab tests within the reference range, but they are not optimal, and a lot of clinical signs, and they do get, and then the cholesterol goes down. You need to know that you can lower the cholesterol when the TSH was above 2. The reference range is between 0.5 and 5.5 or 4.5. And when you're above 2 and you give thyroid hormones, then you almost certainly decrease the cholesterol level. Not necessarily if your TSH is 0.1, 0.5 or 1.1. But if you have TSH above 2, you're hypothyroid almost surely, and you need to have thyroid hormones. Maybe a little question here. How soon can you start hormone therapy immediately after heart attack or stroke? You start it in the minutes you have the heart attack. I had with the vaccine, I had a stroke. I started immediately testosterone. Well, within 2 hours. The sooner you are, the better it is. And then, of course, the stroke 6 hours after, the things were over, but I did have a little mark. But that's the way to change things. I had a patient who had a terrible stroke and arrived much too late in the hospital, 5 hours and a half later, and they couldn't do anything almost, just palliative treatment. Then I negotiated with the top neurological service in Portugal, and the results that they finally, after 36 hours, they accepted to give hormone treatment. And the patient who couldn't talk, who couldn't express, who was paralyzed, half of her body, was almost completely cured after 3 weeks after getting out of the hospital. Without the hormone treatments, this would never have happened. But you have to start as quick as possible. But even if you start later, it still works. I had a patient 3 years later. After stroke, she had a paralysis of her hand, okay, like this. And in 1 year time with hormone therapy, and especially with growth hormone treatment, woof, she could managed everything, do everything with her hand. It hadn't full force after a year, but it was really recovered. And then I know she stopped the treatment and then she declined again. And I think she restarted, but I lost. She was followed by other people. But the effect was really amazing. So you can start very strong. You should start very quickly. Also, maybe another question, because your questions are so interesting. What is the maximum dose of sublingual melatonin for safety usage? Maximum dose that is still helpful would be 100 milligrams to 300 milligrams. You won't have any side effects except being sleepy. It's only if you have to do a lot of activity that you may not take too much, because it decreases the cortisol, then you have a lack of energy, but you can go very high dose. I think you don't have much more efficacy above the 80 to 150 milligrams per day, but it still is good. And I took 2 times 40 milligrams of melatonin when I had that stroke. So it probably saved my brain quite a lot. Huh? Okay, I think that's all. I think we have enough. I thank you for being there. I think you appreciated Michel de Largille as another way of looking at things and makes us think more, etc. Of course, he believes mostly in double-blind placebo-controlled studies, meta-analysis, and I think there are some small studies in animals and also in humans that show, for example, lipoprotein A can decrease by 35% in several studies, but he doesn't attach importance to that because he has his view. It has to be a placebo-controlled study before you accept it. It has to be a large-scale study. And of course, that is his work and his passion, so I can understand it. But I do think that these other studies also are important, can help us give the good treatments to our patients and to ourselves. Thank you. See you later. Thank you for being there. I enjoyed it.